functional and non-functional cusps, right? So, for any functional, non-functional cusp, first we ease it down to centric contacts. No dynamics, no left, right, up, down, nothing, just centric contacts. What do you do when you ask your patient to give a centric contact? You put the paper in the mouth, and what do you ask the patient to do? Ideas? You ask the patient to go tap, 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 tap. Fast. Don't open the mouth too much. Just keep it small, tap, tap. Why do you ask your patients to do this? Suppose we are at the clubhouse and somebody hits a lovely 4. We don't clap wide and loud. We do this, right? Because it's LED, right? So when you do this, you constantly hit the same place. You can try it. You will constantly hit the same place. But if you take it wide and you hit, there is maximum chance that every time you open wide and you close, you won't be hitting the same place. It will be either, haywire. So you should always ask your patients to tap fast without opening the mouth too much, right? Never ever clench. Teeth sink. By the time they come back up again, it will be half an hour, 45 minutes. So you cannot ask your patients to clench. Only light taps, right? So when you've done that, when you ask your patients to tap with we always use the blue paper for centric marks and the red paper for eccentric marks because red means danger, right? So when you take the blue paper and you take the marks, these are the marks that you get in the maxillary artery. Which are these? This is the functional cusp marks, right? Palatal cusps and the mesiopalatal and palatal cusp and the molars. This is it, right? Which is the non-functional cusp marks? The buccal cusps. Remember bull, B-U-double-L? So this is the PU of the B-U-double-L. Bull wasn't for functional cusps. It was for non-functional cusps. Bull is what we are supposed to eliminate, not keep, right? And there is a third point which is important. That is the marginal ridges. The marginal ridges are places where your teeth should contact. Now, in a premolar, it should be buccal and mesial. Buccal, mesial. Consider a molar as two premolars. What happens? Buccal and mesial. That is the mesiobuccal and mesial, distobuccal and the marginal ridge. That is the most important point in a first molar. We were always taught to preserve the marginal ridge if you can when you are preparing the class 1 child, because that is where you get the maximum. Same for the second molar. Now let's come to the mandibular. Functional is the buccal cusps. This I am talking class 1 basically, not going into other situations, class 2, cross bites, basic. So this is the buccal cusp, which is the functional, the lingual cusp, which are the non-functional, and the distal marginal ridges here, which are also functional parts of the teeth. Now, we do not want any contact on any of these slopes. Any of the slopes should not have any contact. Why? Because what happens is, when the cusp goes and hits a slope, what happens is, the tooth slides into occlusion. There. You do not want a hit and slide. Suppose you are walking down a flight of stairs. Suddenly, one stair has been put into a slope. You will slip. What happens to your back when you slip? You spasm. You do not want a slide anywhere. You want flat contacts and point contacts. Okay? Now we come to excursive contacts. So we have understood about centric contacts, holding contacts, right? Maxillary was buccal and mesial. Sorry, palatal and mesial. So it's PN. Okay? Mandibular is buccal and distal. So you need to remember this difference. Now excursive, we do not chew straight. We always chew in excursion. We cut in excursion, we tear in excursion. So just knowing and understanding and eliminating centric contacts doesn't solve any issues, any problem. We need to understand and eliminate dynamic contacts as well. How does the jaw move? When it goes in protrusion, the lower 6 teeth touch the palatal surface of the upper 6 teeth, and it goes in an S shape. That is the anterior controlling factor. Which is the posterior controlling factor? It's the joint. The joint, I am not qualified to touch, and sir is qualified to touch, and sir does whatever he can with it. but we cannot. I cannot even think about touching the joint, right? So we can only change, alter and accommodate the patient to what is there, to what we will do here, right? So this is the protrusive contact. Your lateral pterygoids contract and they pull the mandible forward to bring your mandible edge to it. What should happen when your mandible protrudes? All your posterior teeth here should open up immediately. There should be no lag. One point contact stays there, that is the interference. That will cause your lateral pterygoid to go into spasm. So there should be no contacts in the posteriors when you are going in protrusion. What happens in lateral excursion? Okay? Either canine guidance, it's easier to understand, that's what I am explaining. So the lower tip of the canine will touch the singular and palatal surface of the upper and it will glide past. Now, if it is moving to the right condyle rotates around its axis and the left condyle moves downwards, forwards and inwards. It translates along the glenoid fossa. So the shape of the fossa again dictates how the mandible will move, right? And you see there is a lot of disocclusion and there should be a lot of disocclusion in all the posterior and all other teeth. Okay? Now you put the paper in the patient's mouth, ideally the red paper, and you ask the patient to chew. Left, right. But make sure before you put the paper in his mouth, you should tell your patient, teach your patient how to chew. Take to the left, take it to the right. What happens otherwise? The patient will try his best to take it to both sides, but he will end up taking it only to one side. Every time only to one side. It doesn't help. Train him first. It doesn't take much time. Right? So you see the excursive marks that we prefer to take in the red because that is dangerous. The red is always dangerous. Now, let us look at this canine guided situation. You see this big robust canine, brilliantly big. A person with this kind of a canine and this kind of a canine guidance is definitely a vertical chewing. The size of this canine is so big that horizontal chewing is always blocked by the size and shape of the canine. Now there are studies that have been done on the size of the canine and the pattern of chewing. So if you restore this patient to a group function occlusion, you are basically asking mathematician to do a ramp walk wearing football cleats because you want all those points to touch when she is used to walking on that stiletto. Right? So when you take that guidance in the mouth, only there should be a red line on the tip of the canine, like from the cingulum going down to the tip. None of the other teeth should go. There should be no lines on them ideally, right? Now, even on the mandibular, there should be a mark only on the canine tip and none on the posterior both sides. Let's come to group function. What happens in group function? When you move to the working side, to the right side, suppose, the tip of the canine should touch, right? First premolar, yes. Second premolar, yes. Only the mesopalatal cusp of the first molar. Nothing beyond that. Here you can see it's touching it. So this is an interference. Why not? Nothing behind that. Have you ever seen cutting supari with the supari cutter gently? You put it very close to the joint, to the junction. Then you press, it cuts easily. You bring it away, it doesn't cut. So the amount of pressure that you generate near the fulcrum, where is our fulcrum here? So the amount of force you generate near the fulcrum is tremendous. Any excursive interference near the fulcrum is bound to break the cusp or damage the contralateral joint. Okay? So what are the marks we should find here? Canine, first premolar, second premolar. See, this was the functional point. From here, you see going away to the tip, right? But nothing beyond. There should not be any marks beyond. Conversely, on the mandibular, we should see it on the canines, first, second premolars, initial cusp of the first molar, nothing beyond. Okay? Now,